In this episode of Blood and Cancer News, we have the latest from the 2020 meeting of the American Society of Hematology, including second-line ruxolitinib may be practice-changing for chronic GVHD, durable responses with anti-BCMA CAR T-cell therapy for multiple myeloma, and good results with a 5-minute subcutaneous injection of daratumumab in relapsed refractory myeloma. But our top story today, no benefit from tranexamic acid prophylaxis in blood cancer patients with severe thrombocytopenia. Despite being routinely used in clinical settings, prophylactic use of tranexamic acid, an antifibrolytic agent administered with platelet transfusions, did not reduce bleeding among patients with blood cancers and severe thrombocytopenia. The study was highlighted as potentially practice-changing in a press preview for ASH 2020. For this study, researchers compared tranexamic acid to placebo. They found no significant differences in terms of the number of bleeding events, red blood cell transfusions required, or platelet transfusions required. However, the rate of occlusions in the central venous line was significantly higher for patients in the tranexamic acid group. There was no difference between the groups for other types of thrombotic events. The study included 330 patients who were randomly assigned to receive tranexamic acid at 1,000 milligrams IV or to receive placebo. The treatment continued for 30 days or until platelet count recovery, diagnosis of thrombosis or veno-occlusive disease, recurrent line occlusion, visible hematuria, or physician or patient request to stop treatment. The primary endpoint of the study was the proportion of patients with bleeding of a WHO grade 2 or above over 30 days after beginning therapy. Secondary endpoints included the number of transfusions and the number of days alive without grade 2 or higher bleeding during the first 30 days post-activation of study drug. The researchers reported that the time to the first grade 2 or higher bleeding event was remarkably similar between the two groups. Just under 49% of patients in the placebo group experienced a grade 2 or higher bleed, compared with 45% in the tranexamic acid group. The researchers reported similar results across subgroups, including recipients of allogeneic transplant, autologous transplant, and chemotherapy. The team also reported that there were no significant differences in the average number of transfusion or days alive without grade 2 or higher bleeding. And now ruxolitinib as second-line therapy in chronic graft-versus-host disease. New data from the REACH-3 trial, also presented at ASH 2020, show that ruxolitinib was superior to standard therapy in reducing symptoms of chronic GVHD in the second-line setting, and the results are potentially practice-changing. In the study, researchers compared ruxolitinib with best available therapy in 329 patients with moderate to severe chronic graft-versus-host disease. All of the patients in the study had undergone allogeneic stem cell transplant. They were randomly assigned to ruxolitinib for 6 28-day cycles or to one of 10 options for best available therapy, which was selected by the investigators. The patients continued receiving their regimen of corticosteroids and viral prophylaxis, and antibiotics were allowed as needed for infection prevention and for treatment. The study permitted crossover. Patients on BAT were allowed to start on ruxolitinib on or after cycle 7, day 1, for those who did not achieve or maintain a response, developed toxicity to BAT, or had a chronic GVHD flare. The researchers reported that the study met its primary endpoint, which was overall response rate, with a clear and substantial improvement among patients who took ruxolitinib at 50%, compared with 26% overall response rate for patients in the control group. Ruxolitinib also produced a higher complete response rate at 7%, compared with 3% for BAT. Both key secondary endpoints showed that ruxolitinib was superior to BAT. Failure-free survival was significantly longer in the ruxolitinib group. There was also an improvement in symptoms based on changes in the modified Lee symptom score. 31 patients in the ruxolitinib group and 27 patients in the BAT group died. Chronic GVHD was the main cause of death.
Go beyond the headlines and hear the full story on Cleveland Clinic's Cancer Advances podcast. It's the medical professionals' trusted source for exploring the latest innovative research and clinical breakthroughs happening in the field of oncology. From the highest profile cancer trials conducted at our research facilities to understanding how they impact your patients, Cleveland Clinic's world-renowned experts take a deeper look. Listen to the latest Cancer Advances episode by visiting clevelandclinic.org/Cancer Advances podcast.
And for patients with heavily pre-treated multiple myeloma, the novel CAR T-cell construct ciltacabtagene autoleucel. It produces early, deep, and durable responses. That's according to an update of the CARTITUDE-1 trial. Cilta-cel, as it's being called, is a second-generation CAR T-cell therapy containing two single-domain antibodies targeted against B-cell maturation antigen, or BCMA. Prior results with cilta-cel in the CARTITUDE-1 trial were presented at ASH back in 2019. At ASH 2020, researchers presented a combination of the Phase 1b and the Phase 2 portions of the trial. The trial enrolled multiple myeloma patients with measurable disease as assessed by M protein or by serum-free light chain levels who had experienced disease progression on at least 3 prior lines of therapy, or whose disease was refractory to at least 2 lines of therapy with a proteasome inhibitor, immunomodulatory drug, and an anti-CD38 antibody. Patients underwent apheresis for T-cell collection with bridging therapy allowed until the expanded T-cells could be delivered. Following T-cell depletion with cyclophosphamide and fludarabine over 3 days, patients received a single weight-based infusion of cilta-cel. Of the 101 patients who underwent lymphodepletion, 97 were treated with cilta-cel, 29 of whom were in Phase 1b and 68 in Phase 2. The overall response rate was nearly 97%. That percentage consisted of 67% complete responses, 26% very good partial responses, and 4% partial responses. Among 57 patients evaluable for minimal residual disease, 53 were negative. The median time to first response was 1 month, and at the time of data cutoff, 70 patients had an ongoing response. So what about safety and survival? Well, all patients had at least one hematologic adverse event, 96 of which were grade 3 or 4 in severity. The events include neutropenia, anemia, thrombocytopenia, leukopenia, and lymphopenia. The median time to recovery was 2 weeks for grade 3 or 4 neutropenia and 4 weeks for thrombocytopenia. 5 patients in the Phase 1b part of the trial and 9 patients in Phase 2 died on the study. 5 patients succumbed to progressive disease and 3 died due to adverse events unrelated to treatment. The remaining 6 patients died from treatment-related causes, including 2 patients from sepsis or septic shock and 1 each from cytokine release syndrome, hemophagocytic lymphohistiocytosis, lung abscess, respiratory failure, and neurotoxicity. And our last story in this episode, subcutaneous administration of daratumumab in combination with pomalidomide and dexamethasone is effective for patients with relapsed or refractory multiple myeloma. This is according to results of the Apollo trial, which were also presented at ASH 2020. In Apollo, researchers found that the triplet combination was associated with a 37% reduced risk for progression or death compared with the 2-drug combo of pomalidomide and dexamethasone alone. In this Phase 3 study, 151 patients were randomized to sub-Q dara combination with PomDex, and 153 were randomized to PomDex only. At a median follow-up of about 17 months, the median progression-free survival was about 12 months for patient receiving sub-Q dara and about 7 months for patient receiving PomDex only. The 1-year progression-free survival rate was 52% in the study arm and 35% in the PomDex alone arm. Results were generally consistent across subgroups. Responses were significantly higher in the dara arm. The overall response rate was 69% in the dara arm and 45% in the PomDex arm. The rate of complete response or stringent complete response was 25% in the dara arm and just 4% in the PomDex arm. The safety profile of sub-Q dara in combination with PomDex was consistent with the known safety profile of this combination. The sub-Q formulation of dara was approved in the U.S. in May and is administered by injection into the abdomen over about 5 minutes. Previously, the drug was available only as an IV transfusion. Daratumumab is approved for use in both relapsed, refractory, and newly diagnosed multiple myeloma, either alone or in combination with standard of care regimens. The drug already has 8 specific indications for the IV formulation and 5 indications for the sub-Q indication. And that's it for this episode of Blood and Cancer News. Remember, you can click the links to these stories in the show notes. Blood and Cancer is produced by MDedge editor Jennifer Smith. All our podcasts are produced by MDedge executive editor Kathy Scarbeck.